Thank you. Thank you, Chairperson, for the introduction. And thank you, Dr. Nadeem and the organizing committee of MESTRO for inviting me for a lecture. Today, my topic is bridging the gap between the molecular imaging, theranostics, and radiation planning. It's a little bit a different topic. And I know I'm in between the dinner and the last talk, but I will try to be concise and make it a little bit interesting for you guys. I have no conflict of interest to disclose. There are some affiliations which are under. The outline is about the introduction, theranostic concepts, and potential role for all of PET imaging or molecular imaging in gliomas, meningiomas, and brain metastasis. And finally, I conclude. So patients with brain tumor are often young and socially they are active, and there are currently very limited options available, and these therapies have a dramatically poor outcomes. Molecular imaging is a method that used to identify certain specific biomarkers or molecular targets, and use these informations to tailor the individualized treatment to the patients. Molecular imaging is very valuable tool by giving us certain diagnosis, treatment planning, monitoring, and differentiating between the different grades of the tumors, surgical planning, and guided for the targeted therapy as well. So what is theranostic approach? So what is theranostic approach? That means is combine the therapy and the imaging part, and in a single integrated process. So you will image the patient and you will see the patient and image the patient and see the tumor pattern, and you can treat the patient. And this theranostic become very interesting approach for the management of prostate cancer and especially neuroendocrine tumors as well, and the brain tumors. And as you know that the recently FDA approved certain theranostic drugs and radionuclide therapy for prostate cancer. This is lutetium PSMA therapy, and the lutetium DOTA therapy. This is Luthra, which is approved little bit before the lutetium therapy. And for this therapies for prostate cancer and the neuroendocrine tumors, and it opened the doors for the other tumors, whether you use those radiopharmaceuticals and radionuclides for other tumors like the brain tumors or not. So just an example how good it is, the theranostic or lutetium therapy. So you can image the patient with gallium PSMA, and you can treat the patient with lutetium PSMA, and after the 3 cycles, you have a very dramatic response of this patient with the PSA drop from 473 to 0.6, and patient have a very good response. So then can we translate these things in other tumors or not? Definitely yes. So what is the theranostic concept? We usually image the patient with a certain imaging agent, radiopharmaceutical like gallium PSMA. We image the prostate cancer, and by removing the gallium part, which is used for the imaging, you can use another tracer or another radionuclide. You can treat the patient like lutetium PSMA. You can use for prostate cancer, or lutetium dotatate. You can treat the neuroendocrine tumors. So what next part is the molecular imaging. How molecular imaging can be useful in a brain tumor. PET imaging integrate the metabolic and molecular process. Either you can use that one by seeing the alternation in the glucose in the tumor. Either you can see the amino acids in the tumor, or fatty acid synthesis in the tumor, or certain receptors which are present in certain type of tumors. For example, somatostatin receptors, they are present in neuroendocrine tumors, or cell proliferations. And you people are very keen to look at the hypoxia of the tumor that might change your radiotherapy planning and radiation outcome of the patients. So molecular imaging is very helpful by giving you certain information regarding the tumors. And by this molecular imaging, you can accurately stage the patient. Primary staging you can use for the restaging, or you can see how the aggressive tumors are, and you can predict the grade or predict the therapy response to the patients. So there are certain radiopharmaceuticals available. Number one are the metabolic agents. The very famous FDG is the one, and you can see there is another choline that is used for the synthesis, cell membrane synthesis. Dopamine is another tracer, and you can see the certain receptors. Certain receptors are present in the tumor. For example, the glycoproteins, PSMA are present, and dotapeptide, somatostatin receptors present in the neuroendocrine tumor, and somatostatin receptors also present in the meningiomas. So you can look at the different aspect of the tumor, though it will divide into two parts: metabolic and the receptor imaging. So my slide, I will talk about the gliomas, meningiomas, and metastasis. So first, the meningioma, how it can be used in tumor localization, differentiation of a tumor. It can be helpful in the tumor grading, surgical planning, and for the targeted therapy as well. As you know that the meningioma is the most common primary brain tumor, and approximately 30% of intracranial tumor. It can be divided into grade 1, grade 2, and grade 3, which is anaplastic. Treatment options are from the surgical resection to the radiotherapy, and plus the external beam radiation therapy. And radiation therapy is meant for the patient which have a symptomatic meningiomas, or they are not amenable for the surgery, or it can be combined into an adjuvant surgery, especially for the grade 2 and grade 3 meningiomas. So currently, what is ideal imaging for this is a contrast CT, but how it is helpful, it gives you the lesion characterization, extent of the tumor, and treatment planning, as well as the follow-up of the treatment. But MRI has a limited role in certain locations, that the base of the skull, and sometimes they are unable to differentiate between the radiation necrosis and the viable tumor. The MRI are less sensitive in comparing the residual meningiomas, and sometimes you have a non-specific changes particular due to the radiotherapy. So somatostatin receptors imaging is not recent. It was seen in the indium octotide in late 80s and 90s. Now it is replaced by the gallium dotapeptide, and meningiomas have the high abundance of somatostatin receptors, especially the receptors number 2. And they provide a high sensitivity and accuracy target delineation, and because it is not present in the healthy brain tissue, so you will only see the meningioma part, not the healthy brain parenchymal tissue. And it binds to the grade 1 highly active, grade 2, and to the less extent, a little bit lesser uptake in the grade 3 meningiomas. So I will give you one example. This is a case from our center. The patient was treated post-operative meningioma, and you can see that one. There is a high uptake in the residual part of the meningioma, involving the left sphenoid region. And these are the fuse images with MRI. Shows the 2 minutes. Okay. Now will be another case. Meningiomas, I just skip. It can be helpful. Meningiomas by differentiated the intracranial lesions, especially which are prohibited by the biopsies, like optic nerve meningiomas. And it is very helpful in the radiation therapy planning as well. I'll go for the slide. The case, by integrating the PET CT, it can include or exclude a certain part. As you can see that one, this is a CT planning, and this is the MRI part. If you add the molecular imaging, it adds some part, especially in this area, and it excludes a certain part which is the post-surgical post-surgical non-specific changes. So PET CT, especially with the peptide, is very helpful. This is the ongoing trials are present. There is one recent paper published in Astro Journals. The PET CT detect the new areas in around 28% of the patients, and especially it is very helpful if there will be an osseous involvement. And they found that the significant alteration in target volume around 3/4 of the patient plants. And you can treat the patient with the lutetium dotatate therapies as well. There is an example. This patient was received 2 cycles of lutetium therapy, and you can see that there is a significant response in the with the lutetium PEP. And this therapy is related to the tumor grade. You have a high uptake of the tumor. It will have a better outcome response. Next is the gliomas. Gliomas, as you know, that one is a primary tumor. 65%, 60-70% are malignant, safe resections or adjuvant chemo radiation. PSMA has as you know, that PSMA can be very specific for the prostate, but it is a marker for the new vascularization, and you can use that one in the case of gliomas as well. I just skipped the slide PSMA and just want to show you the interesting case of gliomas. And you can see that this is a normal FDG image in this part, and you can hardly you can see the traditional FDG PET scan. This is an F-DOPA, little bit better delineation of the tumor, and there is a clear-cut winner in this case is the gallium PSMA. So PSMA in the other tumor other than prostate is localized in the tumor angiogenesis. And you know that these gliomas are highly vascular tumor, and you can see that if they localize the tumor only in the tumor rather than in the normal brain canal cells. So this uptake in the PSMA is correlated with the tumor grade and polyphyletic index. High polyphyletic index have a high uptake in gliomas. There are certain trials they can show that the PSMA has a good role in differentiating between the radiation necrosis and the active tumors. This is the case from our center, 69-year-old of GBN, wild type, undergo resection. And you can see that not only one area, there are multiple glioma sites in the frontal lobe and the posterior parietal lobe as well, right posterior parietal lobe as well. So PSMA has a good sensitivity in localizing the glioma. It can differentiate between the active tumor and radiation necrosis. And if you can see that you can treat those patients with the lutetium PSMA as well. This is a case. This is the only case reported. The patient was progressive, a tumor recurrence. If the pre-therapy has a high uptake of PSMA in the tumor, underwent 3 cycles of lutetium PSMA, and you can say that there is a near complete resolution of this glioma lesions. So it can be helpful in not only localizing it. If there's a patient with progressive glioblastoma, you can treat the patients. I can skip the brain metastasis part, but you can localize the tumor with molecular imaging, either with the gallium PSMA or with the other tracer like gallium peptide. And if they are positive, there is always chance you can treat those patients either in combination with radionuclide therapy or alone or in combinations. So this is the case for metastatic renal cell carcinoma. FDG doesn't show up any avid lesion in the brain, but you can clearly see that these are the tumor positive on PSMA because of the tumor vascularity. The high vascular tumors can be positive on our FDG. Just I am to conclude this is the last slide. So gallium PET has a high diagnostic accuracy in diagnosis of the meningioma. It has a good role in radiation treatment planning as well. So you can include or change the planning according to the PET scan, and you can treat the patient with the lutetium dotatate as well. PSMA is going to influence. It can give you the aggressive, the tumor grade. You can patient management, and possibility will guide for the lutetium therapies as well. So theranostic approach in the clinic in intracranial malignancy is an exciting field of the nuclear medicine. You can complement other therapies like radiation therapies or TKI or immune checkpoint inhibitors. Thank you very much.